Asking the right questions will enable you to differentiate between these types of pain.
Hi, my name's Timothy King. I'm a myotherapist.
Hi, my name's Sarah Beach, and I want to give you a really warm Aussie welcome for joining myself and the amazing Timothy King for our online program that we've designed for you together.
We want to unpack for you in this training just how simple some of these solutions can be for TMD, for headache, and also for orofacial, various autonomic orofacial dysfunction.
So if you're a dentist, pain from a dental perspective is really all about the mechanics. It's about tooth wear or broken teeth, trauma to teeth, dental abscess. And so dental practitioners are going to fix pain with extraction or fillings, crowns, bridges, root canals, gum treatments, orthodontics, and these type of things using the appropriate tools. But when pain is the issue, a mechanical solution is not always the answer. The second most common pain presenting to dentists is of muscular or non-tooth origin. These pain patterns, and as you can see, many of them do occur in the teeth themselves. Literally all the teeth, the upper and lower molars, the incisors in relation to temporalis, the molars in relation to masseter, and even the lower incisors in relation to digastric, etc., and pain in various parts of the head are all referred pain patterns. And so tooth pain is very, very possible without having tooth as origin of pain. And so personally, I have treated patients who have had teeth extracted because of the pain, and the pain as a phantom type limb pain, so to speak. The pain resides where the tooth was, and so the tooth was never the problem in the first place. Seen it before. So here's our simple differential diagnosis when it comes to head and neck and especially jaw or TMD pain. We need to be able to differentiate between neurological pain, myofascial pain, and articular pain. If you can get this right, then you will know where to start treatment and you will save a lot of time. It can be confusing because these pains obviously don't exist in isolation, but they interact. And so trying to figure out which is the primary pain that your patient is suffering from is of great importance to solving their complaint. The majority of TMD is either myofascial pain or articular pain, or a combination of the two. The number one reason for misdiagnosis is just looking at where the pain presents, not at the source. And that's a quote by Dr. Jeff Okerson, who's seen some 6,000 plus TMD cases. So there's that statistic. 6,300 patients who had presented with TMD showed 44% had muscle pain compared to 22% with intracapsular or articular pain. Neurological pain is very strong. It's kind of morphine prescription level pain if there is peripheral nerve compression or cranial nerve compression. It's very strong pain, and there will be giveaway signs. There'll be paresthesia or numbness or tingling or burning. To put it simply, sensory changes, very clear sensory changes, and often, as in the case with the trigeminal nerve, the pain will follow a line that literally follows the dermatome or the distribution of that peripheral nerve. There are, of course, paroxysmal neuralgias, such as trigeminal neuralgia, glossopharyngeal neuralgia, which is less common, occipital neuralgia, creating pain up the back of the head, persistent neuralgias, such as post-herpetic and post-traumatic, etc. There's a variety of different types, but if you simply look for these type of sensory changes, then you will be able to identify whether your patient is suffering from whether their pain is primarily neurological. Here's an illustration of the trigeminal nerve with its three branches. The pain, trigeminal neuralgia, may affect all three branches or one of the branches or two of the branches. And because the trigeminal nerve, which is your fifth cranial nerve, innervates the skin, so that sensory touch sensation in the skin, it means that a feather touch or a very light sensory touch on the skin will be perceived as very, very painful, much more painful than pushing firmly against the skin. And so that's a bit of a giveaway for a trigeminal neuralgia. And as I said earlier, being a neurologic pain, it is very strong indeed. Articular pain is sharp and localized, so it's acute and localized. You can see here the image on the right, some facet joints that appear degenerative, and you can see that they're red and angry and irritated. That's to illustrate that articular pain is inflammatory pain. It's when the joint surfaces, the synovial joint, and indeed the synovial membrane around the joint becomes inflamed and irritated and angry. This type of pain you can point to with the head of a pencil, like it's very localized, it's quite sharp, and it will be elicited on movement. And so when the patient is at rest, if it's TMD and they're not moving their jaw at all, it may feel okay. It may not hurt. The more they move their jaw, the more painful it will become. Now, this is a grey area because myofascial pain can get worse with more use, more chewing, etc. However, myofascial pain, as we'll see in a moment, is quite diffuse and dull, whereas articular pain is quite sharp and localized. The image we see on the left is a pretty poor diagram, to be honest, of a temporomandibular joint and the disc in between the head of the mandible, the condyle on top of the mandible, and that coronoid fossa, or glenoid fossa, I should say. Myofascial pain. The referred symptom may present as stiffness, a dull ache, or intense pain. It can be mild to severe, deep and aching, and often at rest. So there's a giveaway again where the pain can, especially myofascial pain especially, can be persistent at rest. Often patients will try and avoid using the jaw or the limb, depending on where their myofascial pain is, and be frustrated about the fact that it's often nocturnal at night, often when they're at rest, that the symptom seems to be all the worse. It's deep and aching, as I said, often at rest. Inconsistent, variable pain. It's poorly localized. Tenderness of the skin is very common, but it's not that same excruciating tenderness that a trigeminal neuralgia will elicit. So tenderness of the skin is common in the region of the referred pain. So in the diagram we see here, if the patient presented with pain in the temple, pain in the mastoid bone, and in the areas illustrated, the skin itself under those pain patterns, even though it's a referred pain, can be tender to touch. You won't have the prickling, numbness, or burning sensory changes that you will see with neurological pain. It doesn't throb, myofascial pain. It's a more constant ache, and it's not sharp or knife-like like articular pain. And so often a patient, particularly myofascial pain and articular pain, will often occur together. Neurological pain may stand alone on its own. Occasionally it may be present with the myofascial and the articular pain. However, it will stand out because of the strength of the neurological pain. And so it will be the first thing that you want to address or refer for if your patient is suffering from neurological pain. If you can differentiate between these three types of pain, and it might be worth just watching this little differential diagnosis again and just making sure it's clear in your mind, asking the right questions will enable you to differentiate between these types of pain. Sometimes there's a blurry line, but often it is quite clear if you ask the right questions.